How are you? My name is Maranga Simon, and today I want us to look on the management of diabetic ketoacidosis. It's the complication of high blood sugar or hyperglycemia. It can be either as a result of type 1 diabetes or type 2 diabetes, but mostly it is as a result of type 1 diabetes, what we also call juvenile diabetes. Therefore, what you need to understand when it comes to the management or the treatment of diabetic ketoacidosis, the therapeutic goals of diabetic ketoacidosis or diabetic ketoacidosis management include optimization of the following 4 major steps. First of all, volume status. You need to look on the volume status. Secondly, hyperglycemia and ketoacidosis itself. That electrolyte imbalance or electrolyte abnormalities. And fourth, potential precipitating factors. For instance, infection. Infection is one of the major precipitating factors of diabetic ketoacidosis. Now that we have understood the goals of our management or our treatment, let us now look on the various or important steps you should follow in the earlier stages of the management of DKM. First of all, collect blood sample for metabolic profile before initiation of intravenous fluids. Secondly, infuse 1 liter of 0.9% sodium chloride after collection of the blood sample. That ensure potassium levels they are above 3.3 before initiation of insulin therapy. Supplement potassium intravenously if needed. That means if your potassium level is below 3.3, because you need to keep your potassium levels at least between 3.3 to 5.3, because remember, insulin is going to lead to the movement of the potassium from the extracellular to the intracellular, and therefore it is going to cause hypokalemia. Remember, hypokalemia may result to cardiac arrests. It's going to cause an arrhythmias, and therefore to avoid all those complications, it is important for you to ensure that your potassium levels they are at least 3.3 and above. Fourth, initiate insulin therapy only when steps 1 and 3 are executed. I mean, ensure you have collected the blood sample and you have gotten back the result from the lab that your potassium levels they are above 3.3, or you have already initiated or you have started the KCL, that's potassium chloride supplementation. That's when you can start or you can initiate the insulin therapy. What are your treatment targets, or what are your metabolic treatment targets? Serial measurements every 2 to 4 hours of metabolic parameters are required to monitor therapy and then confirm resolution of DKA. DKA is resolved when? Or when do we say that your DKA is now resolved? First, your plasma glucose must be less 200 to 250 milligrams per deciliter. Secondly, serum bicarbonate concentration is equal to or more than 15 milliequivalent. Third, venous blood pH is equal to or more than 7.3. Next, your ion gap should be equal to or less 12. Note, if plasma glucose is below 200 milligrams per deciliter, but bicarbonate and the pH are not normalized, your insulin inhibition must be continued and dextrose containing fluids started. The latter approach will continue to suppress ketogenesis while prevention of hypoglycemia. Let me summarize for you the management of diabetic ketoacidosis. First, commence the intravenous infusion of 0.9% sodium chloride. That is 1 liter per hour. Secondly, after getting the results on potassium levels, then check if your potassium levels they are above 3.3 millimoles. If yes, then give a bolus of insulin 0.1 units per kg. Then continue with the insulin infusion at 0.1 units per kg per hour. And what if the potassium levels they are below 3.3 millimoles? Then you have to replace the potassium levels until you get the 3.3 millimoles and above. Next, if you check your blood sugar levels, then find that your blood sugar levels after 1 hour of the insulin commencement, and of course also of the replacement of the potassium levels if they were low, and find there's a decrease of the sugar levels to less than 10%, then you need to give a bolus of the insulin, that's 0.1 units per kg. After giving the insulin bolus, then continue with the insulin inhibition at 0.1 units per kg per hour. Again, after doing the test, then you realize that your sugar levels now they have dropped and they range between less than 200 to 250 milligrams per deciliter. Then lower or reduce the dosage of the insulin infusion that you are giving. That means you are going now to give the insulin infusion at 0.05 units per kg per hour. And of course, now you are going to commence the dextrose 5% at 150 to 250 mils per hour. After doing another test, Remember, you are supposed to do a test 2 to 4 hours, and now you have the result out. Then you realize that your sugar levels, it's below 200 to 250 milligrams per deciliter. And also your bicarb levels, it is equal to or less 15 milliequivalent. Then if the current rate of your insulin that you are giving, it is above 2 units per hour or equal to 2 units per hour, then reduce your insulin infusion by 50% and continue with the dextrose 5%, that is 0.45% sodium chloride at 150 to 250 mils per hour. If current rate of insulin at your administration is below 2 units per hour, then continue with the same dose of infusion and change the fluid to 0.45% of 10% dextrose at 150 to 250 mils per hour. If your blood sugar is at less 200 to 250 milligrams per deciliter, and the serum bicarbonate is above 15 or equal to 15 milliequivalent, and your anion gap, it is less 10 to 12, then stop the IV infusion, stop the IV fluids, and start the subcutaneous insulin, that is 0.5 to 0.8 units per kg.